is requested to mute themselves. They're going live.
Okay. Good luck, everyone. Okay. Hope am I audible and visible, everyone. Good morning, everyone. Greetings on behalf of BD India. My name is Nikita, and I'm a marketing manager handling this chronic dialysis portfolio at BD. It's my pleasure to welcome all of you at GIMS 2021 Glide Path Insurgent and Maintenance Symposium. The meeting format is case discussion, case presentation on glide path, followed by panel discussion and question answers. And thank you once again, everyone, for joining this event. Let me introduce the faculty for today. We have a renowned faculty joining with us. First, we have Dr. Hemant Mehta. Dr. Hemant Mehta is an interventional nephrologist and a renal physician. He has been associated with Leelavati Hospital and Research Center since its inception. His experience include clinical experience in nephrology for 28 years, teaching experience 16 years, and he has handled 150 vascular access procedure in last 18 months. He has immense experience and expertise in procedure in nephrology, including vascular access for hemodialysis, interventional nephrology, and critical care nephrology. He is a founding member of Mumbai Nephrology Group and holding position of Joint Secretary cum Treasurer from its inception in 2009 till 2016. And he is a founding trustee of Indian Society of Nephrology West Zone chapter. He is recognized by American Society of Diagnostic and Interventional Nephrology as a fellow with a title of FASDIN February 2016 during 12th annual conference of ASDIN at Phoenix, Arizona, USA. He has 32 publications, 16 research topic and 56 scientific presentation on his name, and he has conducted number of workshops in last 20 years. He is an expert in interventional nephrology and a perm care placement. Thank you so much, Dr. Mehta, for joining us today. We also have Dr. Valentine Lobo today with us. He is a consultant nephrology practicing in KEM Hospital, Pune. He has more than 18 years of experience in his field. He has done MBBS from BJ Medical College from Pune, MD with first rank in Pune University examination from KEM Hospital, Pune, and done his DNB from MPUH Hospital with winner of HL Trivedi Gold Medal for securing first rank in India in his DNB exam. Dr. Lobo awarded with first prize for poster presentation on early post-transplant enzyme urea at the ISN 2001. His paper has published in 6 international and 16 national publications. He has experience of more than 500 tunnel catheter placement cases. And last but not the least, today we have Dr. Hardik Patel. He is a consultant nephrology working at MPUH Nadiad. He has 5 years of experience in his field. He has done his MBBS from NHL Municipal Medical College Ahmedabad, MD from BJ Medical College Ahmedabad, and DNB from MPUH Nadiad. His area of interest is interventional nephrology. Under his guidance, almost 50 tunneled catheter insertion performed every month at MPUH Nadiad. Once again, thank you all the faculties for joining for this event and welcome everyone. Before I begin, couple of things. You can type in your questions in the chat box. You can see, and we will take up all the questions at the end of the event. And also a quick disclaimer from BD India. So this is just a disclaimer from our end, and now I'm handing it over to Dr. Mehta.
Sorry. Hi, good
So
morning,
we are now
everybody.
ready.
Thank you. Yeah, thank you, Nikita, for your kind introduction, and I thank BARD India for having organized this symposium. As it says, it is going to include both about insertion technique and maintenance. So, what I would do is first touch upon briefly over a video for 12 minutes or so the method of insertion, and we will halt as and when required to give the explanation. If anybody has a question at that time, they can also raise a question so that we can address the query right there rather than going back to the video. Once we finish that, we will come to the panel discussion where we discuss about the maintenance part of the catheter, where Dr. Lobo and Dr. Hardik Patel will also join in to give their expert views on the same topic. So, without much ado, let's start with the video. And whenever I tell you to halt, pause, whatever, just do that. So,
Go to the next slide, Amit. Also the video, please.
yeah. Okay. So, as we know, tunnel catheters are, or for that matter, catheters are the lifeline of the patient, and we may place the catheter. We should be doing it in an absolute sterile environment, and it should be done under sono guidance and also the image intensifier. So, 1 minute, 1 minute. Hold. Please pause. Yes. Now go back little bit. Back, back. Yeah, hold on. So the first thing it okay. The first thing we would, yeah, please pause. The first thing we would start with is doing the, when the patient is on table, we always screen for the size of the vessel and also see where the vein lies with respect to artery, because it is presumed that the vein is lateral to the carotid artery, but that is not true in 100 out of 100 cases. You can have variations, and in few percent of cases you do have the other way around. Sometimes the vein is lying just above the artery or below the artery, and things like that do, variations do occur, and that's why we do this. So we have placed it also to realize that the placement of the probe is quite low down just above the clavicle, because we nowadays prefer to do what we call as low lateral approach rather than the anterior approach. If you see the difference between our placing the catheter, the puncture side will be totally different from the intensivist putting the central line, where they prefer to go as high as possible and sometimes just below the pinna. We don't do that, because if you do that, then there's going to be a very acute sharp curve, and you will end up with kink in the TCC, which will be useless. So lower lateral approach is the preferred one. Please play the video. So as you see, as you scan it, yeah. So pause. Please pause the. What? What happened? Yeah, pause. Pause. No. One step more. Start and pause. We need to see some picture on the screen TV inside. Yeah. All. Okay. Pause. Yeah. Fine. So the larger structure is the artery, the smaller one is the vein. If you press the probe, you will see that it's a compressible structure. Don't go by the red and the blue color, because you have to follow the principle of BART. So anything which is flowing towards blue is the one which is flowing away from the probe, and what is flowing towards the probe will be red in color. So you can just change the probe and get a blue and red color. So red and blue color are actually not going to be important in the picking up of whether you are in the artery or the vein. So we have marked that. Please play the video. So and make sure that where we are going to be puncturing from. So once having done that, you, and if you realize also that if you come anterior, there is a very high risk that you will enter into the artery if you go deep. So you have to come from laterally so that you can avoid the artery altogether. Now, after that, the next most important thing is, for the maintenance and for the long term longevity of the catheter, is a sterile preparation. And this is how we do. We take chlorhexidine scrub first, followed by chlorhexidine solution, which is now a standard recommendation. Betadine is actually given up, but we are still old timers. So after scrubbing it with chlorhexidine scrub and chlorhexidine hand rub, we still try to paint it with betadine, but you may or may not do it. After this, as you realize, the patient is covered fully, and we do this procedure under absolute local anesthesia. No conscious sedation is given, though some people prefer to do that, but we like the patient to be conscious. And to prevent the infection, the other thing which has been recommended is that if you see at the end of this draping, that only the part where we are going to operate is open. The whole body is going to be covered, and that's again the idea. I mean, we can't be doing a tunnel catheter insertion with only whole towel placed on the head with hole seen in the right jugular area and everything else open. That should never be done. Everything should be covered completely. Patient is on oxygen and he's been told that not to worry. He won't feel breathless or anything of that sort. And so you put your sterile towels liberally and cover from all the sides. Now see, only this part which we are going to, everything is covered, no other part of the body. The next step is to prepare the probe and make it sterile. So this is your probe cover. It can, there are various ways of doing it, but this is good enough. So we have taken the sterile cover and put the jelly inside, put a probe on it, and then invert it. This is all sterile. Okay. Once you do this, somebody will pull it out and the whole thing becomes sterile now. So you are comfortable doing it. Okay. Just secure it, make sure that there is no air or anything of that sort, otherwise that will come in your view, because now the view is not going to be as easy as it would be without this plastic on top. So, no, secure it with uh, plastic thread which comes along with this cover, and make sure that you are proper and perfect in this. After that, you start your pro. Now we are going to do what is called as low lateral puncture, give local anesthesia, and if you see the needle coming from the lateral side, okay, and that's about it. So once you get free flow, put a guide wire. Once we start this, we don't need the sonocyte. Now we need the screen to make sure that we are going into. Now, once we are doing that, this should be done under the fluoro guidance. Now, as I will show you, as the fluoro is kept on, you will realize that the wire comes up to the right atrium and sometimes tends to get curved into the right, as you see it here. Now see, so you need to manipulate it. Tell the patient to take a deep breath, and as he takes that deep breath, just give a little push, and it gets flipped into the IVC. So once you go into the IVC, bury deep into the IVC. There are three advantages of doing this. Number one, the most important thing is to realize that once you have crossed the diaphragm, you are definitely in the vein. Number two, it will obviously not cause arrhythmias. And third most important thing is you will be assured that it doesn't flip back into the RA because the flow is very high. Now we have marked the catheter as you saw in the. Can we little just pause and go few pick the frames backwards? Few frames. Few back, 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 still back, back, still. Now show me the screen, the fluoroscopy screen. Back, get back, back. Yeah, one. Yeah, okay. So if you see now my wire is there and I placed the catheter on the body, which you can see is lying approximately in the middle of the right atrium. Now, how do you make out that this is in the right atrium? See, what you do is you see carina, which you can't see because there's a label there. So you mark a carina and usually the middle of the right atrium is about 5 centimeters, though it is variable. uh, and when we say 5 centimeter, it is roughly equal to two vertebral body height. Each vertebral body is about 2.5 centimeter. So if you mark the carina and you come down by about two or sometimes two and a half vertebral body below the carina, and that is where you place your tip of the catheter, you are going to be exactly into the middle of the right atrium. Now, there is a debatable point. Hold on, please don't play. There is a debatable point whether you should be placing your catheter into the middle of the right atrium, or whether the tip should be in the upper one third and lower two third of right atrium. This debate has been there over the years, more than 20 years. I have preferred to place the catheter in the middle of the right atrium. When we used to use staggered tip catheter, I used to even place it in the lower, upper two third and lower one third, because those two tips of the catheter used to be like this, and when the catheter would move, you have to make sure that both the tips are moving with the breathing, with the respiration within the right atrium only. Otherwise, if the proximal end gets pulled into the SVC when the patient breathes, you are going to get flow problem. That part of the problem has been overcome by this type of glide path catheters, which are called symmetrical tip catheters. So if you are in the middle of the right atrium, even the patient is huge, has broad shoulders, large breast, and even if the patient is sitting up and taking breath, it will still have to be seen that the catheter movement, both tips are within the right atrium, so that you have both smooth inflow as well as outflow. Please play the video. So having marked this, so now it's like marking the surface anatomy. This is what we have done it. So we know where the tip is. Now somebody is holding it, and now we are going to mark. We have marked the full thing, where the insertion point is going to be, where the tip is going to come with that. Okay, now we are going to infiltrate the whole thing with the local anesthesia, so that the patient has no pain. So again, trying to emphasize that patient is just under this much anesthesia and no other thing. Please pause. Now, one more thing I'm going to do is, now see, this is going to be your insertion point. Sorry, this is going to be insertion point coming up to the HAV, and then this is going to be inside. Instead of going straight, I will make a cow like this. It's a bow like this. Okay, so I'll show you that. So let's finish with this infiltration, and I'll show you. Now, please play. So the whole tunnel has been infiltrated. Now make a nick here, just to be sure that we are going to be uh, able to make a curve here very decently. So a small nick, a small blunt dissection, just to make what we call as a fossa. As you will see this, just 2 millimeter, 3 millimeters more than enough for the catheter's tunnel to be very smooth and kink free. If you have not done that, if there is some fibrous band lurking there. So once we are ready with that, now we are loading the catheter, uh, which comes with heteromatic end, so that it's easy. Now you lock it with this and make sure that you are very perfect. Now it's already curved, but I prefer to curve it more. So now this is what I was showing you. Now see how it's going to come. Uh, it's going to be coming straight and then taking a curve onto this. Okay. Now once you come out, see how the curve has come. Slow, and so this is how things will be. Okay. Now we know that it's going to come down. This is just pointing up because we are still outside, and the wire is inside. You start with the dilator. You put the first 12 French dilator, then 14 French dilator, and then the 16th French dilator, which comes with the dilator with spillover sheath. So everything is put inside. Everything is under the fluoro guidance. And every time you go in, you make sure that your wire tip is pointing outwards so that there is no question of losing the wire. Once you are in, now this is of course unidirectional. This sheath comes with a unidirectional valve so that it doesn't uh, allow the bleeding to occur. Neither does it pull the air in, so there is no chance of air embolism. Once you have pushed this in completely, now you are going to peel away the sheath. And once you do that, check the tip and the cow position, and you'll realize that how smooth, gentle. Now you see what I was. Please go back, pause, and go back to 2 frames. Yeah, uh, one. Just play, pause. Oh, not this. Yeah, hold, no, no, 1 minute. Okay, no, little. Go further. Go fast, fast, fast. Further, further. Go. Still, go, go. 1 minute. No, little back now. Pause and come back. Come back few frames. Please come back. Ah, hold on. That was the one. No, back. Pause it and then just move the cursor. Yeah, little back. Don't play. Don't play. No, no, don't play. Just move that. Move this part backwards like this. Move this way like. Don't play. Put it on pause. Put this on pause. Please press this button. No, listen. Press this button.
Pause
The
the
play
video.
button. Yeah.
No,
Now,
video is paused. Yeah.
no. Now you just move this cursor backwards so that move it slowly. Yeah, little. Just little, little. Still more. No. Back. No, you're too much. No. For, hmm, back. No, back. We are too much in front. Back. No. Okay, play. We'll see.
Yeah.
Play.
When it comes, just pause.
Yeah.
Just keep it ready. When it comes, just
Yeah.
pause there.
Okay.
Yeah.
Pause. No.
Pause.
That's so. What's
Yeah. It's
happening?
taking. Sorry.
See that picture I wanted to show the cow. 1 minute. Just before this.
Just go 30 seconds back, Chirag, and then just play. And when it comes, just pause.
Yeah.
Yeah. Now play.
Hold on.
No. Okay.
Oh. That was the picture I wanted. Please go back. I just want to show little 1 frame back. 1 frame. No. Yeah. Okay. Play. Pause. No. Pause. No. 1 minute. Remove my hand. 1 minute. No. Yeah. No, it's not. Wow. Okay. Fine. Don't move. Now you see this. This is taking the cow like this. So this is what I want to show you. You can come from this point to this point in this direction straight, but I've come this way. Can you see that? Okay. So play. This will translate into a smooth curve as you will see it here. Play. Now see that catheter is lying right into the atrium, and now see the curve. Absolutely smooth. So low lateral. Now this is how we check the flow. We make a negative pressure and open the clamp. This is a 10 cc syringe. So if I am going to be able to aspirate this blood of 10 cc in 1 to 2 seconds, it translates to flow of at least 300 ml per minute on the machine. So that's why we do. Now you see this, I'm taking the suture, I put the catheter right into till the thing is buried inside. Okay, now again there are questions about this. Some people feel that you should not bury the whole catheter inside. Only half of it should be there because the cuff is now too much deeply placed. And when you want to remove the catheter, it becomes difficult. Otherwise, you need to take an extra incision on the cuff to remove the catheter. We don't do that. If and when we have to remove the catheter, we go from the same entry point where it is and dissect the tunnel all the way bluntly down and make sure that we have removed the catheter without taking any extra sutures. The exit site is just rest and it heals. This is how you take a mattress suture over the point where it has been inserted, so that you are also assured that it heals well. Only thing you have to be sure that you don't injure the catheter which is just lying there. This is again checking the flow, getting a flow of 10 ml in less than 1 to 2 seconds. Just see how it fast comes. So if you get this flow within a fraction of a second, that means you're going to get good flow. And now we lock it with a heparin of 25,000 unit per 5 ml. We go zero point 0.1 ml to whatever is been given uh, by the manufacturer, which is just the capacity of the catheter. We add zero point 0.1 to account for the loss which would occur by heparin getting adherent to the syringe and catheter, etc. And then make sure also that you take proper care and do the proper dressing yourself only. The advantage on this catheter kit is that it comes with a free tegaderm, so we don't have to spend for it, like unlike others. And then after having secured it from top, all that you need to do is also secure the bottom part, so you can take a micropore or some similar dressing. And this is how you secure the exit point also. And the third step would be to secure the open ends of the catheter. So this is how it has been secured now from both, like 360 degrees at the exit side. And now we take gauze piece and wind it around and lock it with another micropore like this, so that your whole thing is now covered. And that's about it. So this is how you place the catheter and then you are ready to move on. Yeah, we can stop the video and we can go to the panel discussion. Yeah, so Nikita, shall we start with the panel discussion?
Yes, Dr. Mehta, we can start with the panel
Yeah.
discussion.
So can I start with Hardik? So Hardik, first tell our listeners about what would be the indications for this tunnel dialysis catheters.
Uh, uh, Good morning, sir. Thank you for the excellent video. Indication would be the any patient who requires dialysis beyond 3 weeks, I would say, especially any patient who is in chronic kidney disease. And now even to we have changed for our practices even in AKI, certain situations like cast nephropathy or anti-GBM dialysis dependent patients, we prefer going for a tunnel catheter because we know it is they are unlikely to recover in weeks or days. They will be with us for weeks together, and they will be on the more on an outpatient basis once they are stable. So any AKI patient who are likely to be remain on dialysis for more than 2-3 weeks and who are likely to be our outpatient patient, I will still prefer a tunnel catheter, and
So
especially older patients.
No, no, why older? Even younger patient. So basically, what would be your message to